Good evening and welcome to tonight's webinar, brought to you by JBJS Reviews. Tonight's topic examines two surgical approaches to anterior shoulder instability, open versus arthroscopic treatment. This is Mark Swinkowski, Editor-in-Chief of JBJS. Through technology platforms such as this webinar, we are able to provide content that is important, timely, and available in an interactive format in the comfort of your office or home. The surgical approach to anterior shoulder instability, open versus arthroscopic, has been hotly debated in the orthopedic community. During the next hour, you will hear from Dr. Frank Cordasco, who will present his JBJS Reviews article entitled Open and Arthroscopic Anterior Shoulder Stabilization. During this webinar, you will also hear from two shoulder experts, Dr. Andrew Green and Dr. Brad Parsons, who will share their thoughts on Dr. Cordasco's presentation. Tonight's webinar is moderated by Dr. Thomas A. Einhorn, JBJS Reviews Editor. At the end of the webinar, all experts on the panel will address questions from the audience to provide further insight into the surgical approaches to anterior shoulder instability. I know that you will find the next hour stimulating and informative. Before we get started, I want to make sure you get the most out of this webinar. There are a few ways you can participate in tonight's event. You are welcome to ask one of our panelists a question by simply typing your question in the Ask a Question bar, which you will see below the slides. When you're done, simply press Submit. Feel free to submit a question anytime during the presentation. You can also read our speakers' biographies. The handout widget at the bottom of your screen contains the PDF of the articles presented tonight. Additionally, the slides from tonight's webinar will be emailed to you tomorrow at noon. Now let me introduce our moderator, Dr. Thomas Einhorn. Dr. Einhorn is a professor of orthopedic surgery and director of clinical and translational research development at NYU Langone Medical Center in New York City. He's also the editor of JBJS Reviews and has authored more than 230 peer-reviewed articles. His career is dedicated to exploring the role of regenerative medicine in orthopedic surgery.
Thank you, Mark, and thank you for the privilege to moderate what I anticipate will be an exciting and informative event. Tonight we have three outstanding speakers who are experts on shoulder instability. The article being presented tonight, Open and Arthroscopic Anterior Shoulder Stabilization, was co-authored by Dr. Frank Cordasco and published in February 2015 in JBJS Reviews. Dr. Cordasco is an attending orthopedic surgeon in the sports medicine and shoulder service at the Hospital for Special Surgery in New York City and professor of orthopedic surgery at Weill Cornell Medical College. Our first commentator, Dr. Andrew Green, is chief of the Division of Shoulder and Elbow Surgery and an associate professor of orthopedic surgery at Brown University's Warren Alpert Medical School in Providence, Rhode Island. Our second commentator, Dr. Bradford Parsons, is the chief of the shoulder service and associate professor and residency program director in the Lenny and Peter W. May Department of Orthopedic Surgery at the Icahn School of Medicine at Mount Sinai in New York City. We will save the last 15 to 20 minutes for questions from the audience. You can send questions in at any point during the presentation. Dr. Swinkowski will help me identify the most relevant questions, and I will direct them towards one or all of the speakers. Now let's begin with Dr. Frank Cordasco.
Thank you, Tom and Mark. It's a pleasure to participate in this webinar. I would like to acknowledge my co-authors on this paper, Peter Fabricant, Sam Taylor, Maura McCarthy, Elizabeth Gosden, Kahal Moran, and Richard Kang. The shoulder joint is the most common joint to dislocate among major joints. 90% of these are anterior dislocations and involve the classic Bankart-Perthes capsulolabral lesion. We know that there's an inherent capsular stretch associated with these lesions prior to failure from bone. The natural history of shoulder instability has been carefully identified over the years, and this paper from Carter Rowe nearly 60 years ago demonstrates that 20% of the cohort in his population was under the age of 20. Additionally, we know that the age at the time of the dislocation is inversely related to the recurrence rate. We also know that there's a gender-specific difference with females achieving a 50% recurrence rate approximately 11 years before males do in their late 20s. This Instability Severity Index score was popularized by Pascal Boileau and others. It's a 10-point scale, the first three factors of which are associated with age, degree of sport participation, and type of sport, and the next three are related to shoulder hyperlaxity and radiographic bone loss. In their original paper, Balg and Boileau in 2007 found that arthroscopic stabilization under the age of 20 led to a 31% recurrence rate, and if the score was 6 or higher, a 70% risk of recurrence. 7 years later, they have now recommended a Latarjet with an ISIS score greater than 3. This differs somewhat in philosophy from most of us in North America. The Beighton score for hypermobility is also useful. This is a 10-point scale as well, which measures ligamentous laxity in multiple joints. But remember that shoulder hypermobility may exist with a low Beighton score. Glenoid bone loss is a critical risk factor. Multiple authors, Itoi, Bankart, Yamamoto, have all demonstrated that stability decreased progressively as the degree of bone loss increased. Measuring these lesions can be difficult. Sugaya and others have used 3D CT scans with an en face view and the humerus subtracted. A paper last month from the Rush group demonstrated that diameter-based glenoid bone loss quantification overestimates true glenoid bone loss. We also are aware of the glenoid track, and we know that the length and depth are perhaps less important than the location of the lesion. This paper from Bob Arciero and colleagues at UConn, along with Matt Provencher when he was in San Diego, reviewed combined glenoid and Hill-Sachs defects on glenohumeral stability. They found that these bipolar defects were additive and also had a negative effect on stability. Even small degrees of glenoid bone loss in the range of 2 to 4 millimeters or 8 to 15% when associated with a Hill-Sachs lesion would compromise a soft tissue repair, and therefore bipolar defects in high-risk athletes may require more than an arthroscopic Bankart alone. This is a large series from Canada, nearly 6,000 stabilizations over a 5-year period. They found a high risk of failure in those under the age of 20 with 3 or more pre-repair dislocations requiring a reduction. They also found that open stabilization led to fewer recurrences in this young cohort. Our recent experience at HSS reviewing 90 athletes under the age of 25 revealed that of these 90, 15 underwent open stabilization for 16%, but of the 75 athletes that had an arthroscopic stabilization, the recurrence rate was 13% with a return to sport of 87%. If we look at the number of pre-op dislocations in this group, it was directly related to the recurrence rate, as you can see, with more than 5 episodes of instability revealing a 50% recurrence rate. So these are all post-operative recurrence risk factors that I've just reviewed, including age, gender, sport, bone loss, ligamentous laxity, but perhaps the most significant is the number of preoperative instability episodes. It's important to elicit this in the history by beginning with determining the age at the time of the first instability episode, the mechanism of injury. Was it the dominant shoulder? Is there a contralateral history? What is the athlete's sport, and what's the position within the sport? And what's the level of competition within the sport? What has been the time interval between episodes, and is there a diminishing interval with each episode? And finally, the length of time before the reduction. Recent paper from Denard, Bankart, and colleagues demonstrated that if the shoulder has been dislocated for 5 hours, that individual is likely to require a Latarjet. On physical exam, it's useful to identify the Beighton score, assess the axillary nerve, look for provocative signs for which we're all familiar, and check for mid-range instability. If the athlete is apprehensive below 60 degrees of elevation, this is something to note. And in those over the age of 35 or 40, remember to assess the integrity of the rotator cuff. It's important to obtain an AP and internal and external rotation to look for bone loss on either side. And remember that if you see a Hill-Sachs on an external rotation view, this is likely to be moderate or large in size. It's important to obtain axillary views, either supine or prone. The French like the Bernajoux view, which is difficult to obtain technically, and many of them actually obtain fluoroscopic imaging, identify the spot, and then shoot the film, which becomes problematic in most practice situations. And the striker notch is useful if you suspect a large lesion. Some of these films have been obviated by additional imaging, such as a CT scan. In my hands, I typically will indicate an athlete for a CT if there's a suggestion of bone loss on plain radiograph, if one has a clinical suspicion in that the athlete has had more than 2 to 3 instability episodes, or if there's mid-range instability on physical exam. These studies can be quite useful, as we know. MRI is helpful to assess the soft tissues further in the form of Alpsa lesions, Hegel lesions, patterns of marrow edema if you're concerned about direction, and the cuff in those older patients. Non-operative management, of course, begins with an acute dislocation and a prompt reduction either on the field or on the sideline. Assess the axillary nerve prior to the reduction. Immobilize in a sling for comfort. There does not appear to be a significant difference between longer mobilization and shorter mobilization. And while there's been a lot of discussion about the location or the method of immobilization, should it be an internal or external rotation, the literature comes down on both sides, and for most practitioners, internal rotation is simpler. Current trends are useful to identify. This paper from Zhang, Owens, and colleagues looked at trends in the U.S. and found that nearly 90% of shoulder stabilizations are performed arthroscopically, that the incidence doubled between 2004 and 2009, and that within the open group, the number of open Bankart repairs decreased while open Latarjet procedures increased. Contrast this with France, where the Latarjet is the most common procedure performed. This recent paper, once again from Boileau and colleagues, looked at the recurrence rate and found that at 6 years, there was a recurrence rate of 10% with the Latarjet versus 22% with the Bankart group. They recommend, once again, a Latarjet with an ISIS score greater than 3. If we look at open versus arthroscopic techniques, in the literature, systematic review and meta-analysis of 18 studies by Lenters, Mattson, and others found that arthroscopic repair yielded higher rates of recurrence as well as reoperation. This randomized controlled trial from Motati and colleagues once again found that arthroscopic repairs led to an increased recurrence rate of 23 versus 11%. And finally, there are multiple papers that have found that arthroscopic repair equals or is better than open reconstruction. On the glenoid side, there are multiple operations that can be performed. The Latarjet, of course, is popularized. This is the lying position of the coracoid with 2 screws, classic versus congruent technique, triple blocking effect with bone, the muscular sling, and ligament reconstruction. The Bristow, described by Helfet, the standing position of the coracoid with 1 screw, perhaps slightly more prone to non-union or hardware failure. And then finally, free bone graft, not a new concept, described by Eden and Hibinet independently using iliac crest, or allograft reconstructions as popularized by Provencher with the distal tibial plafond bone block. On the humeral side, you have several approaches. One can approach the bone loss anteriorly with an open soft tissue stabilization or Latarjet, posteriorly with a soft tissue reconstruction only, popularized by Gene Wolfe with an arthroscopic Remplissage. And if the bone loss is significant, one could use a humeral head allograft as popularized by Miniacci. I prefer to perform open Bankart repairs in the beach chair position with a combined anesthesia, arthroscopic assessment in all cases. I proceed with a skin incision using the Leslie and Ryan extended anterior axillary approach, deltopectoral approach, and then on the subscapularis, typically a lateral takedown versus a split for simpler Hegel-type repairs. Bankart repair can be performed with 1 or 2 rows, typically a single row repair, and then a selective capsular shift, either splitting in the classic near sense between the middle and inferior glenohumeral ligament, which is less common in my experience for these athletes, than simply not splitting it at all. For advanced arthroscopic techniques, I prefer the beach chair, combined anesthesia. I use an arm positioner for traction and a bump in the axilla to help expand the inferior recess. Using a 30 and 70 degree lens is very helpful. Percutaneous approaches and double row techniques. We published this a little over a year ago. It's not a new concept. Laurent Lafosse described the Cassiopeia technique a few years ago. Peter Millett has described this technique for use with a bony Bankart lesion. We'll move to a 2-minute video at this point in time. While viewing posteriorly with a 30-degree lens, we can see a capsulolabral avulsion anteriorly with articular cartilage damage as well. Labrum being probed. Here we're using a samurai device to elevate, in this case, an osseous fragment which was identified preoperatively upon CT scan imaging. And here a blunt elevator is used to finish the mobilization. Here we are using a 70-degree lens, once again via a posterior portal, to facilitate visualization of the mobilized fragment as well as the anterior glenoid and scapula. Here we're measuring the distance from the tip of the coracoid for placement of the percutaneous needle, which is being passed through the soft tissue. The guide wire is now passed through the needle, and the dilating sheath is passed over the guide wire bluntly to avoid injury to the musculocutaneous nerve. The drill guide has been passed over the dilating sheath, and for the duration of this portion of the procedure it will be left in place to avoid multiple percutaneous punctures. Here we're placing our first medial row anchor. This is the most inferior anchor placed within the medial row construct. Here we're retrieving the sutures through the drill guide out the anteroinferior portal. The suture limbs have been passed through a knotless anchor device and are now being tensioned appropriately prior to implantation within the lateral row. This final arthroscopic view demonstrates a satisfactory reconstruction using the convergent technique. This is an evidence-based treatment algorithm which was part of the paper, and as you can see here, after the initial event, radiographs are obtained. If there is a large osseous defect, it should be measured. If it's more than 20% of the glenoid surface without a bone fragment, typically this requires a glenoid augmentation, and in my hands that would be a Latarjet in this setting. If there's a viable bone fragment and it's an acute injury, one can choose to perform an arthroscopic double row repair, much as described by Peter Millett, or an open reduction and internal fixation. If it's a fragmented or comminuted lesion, one would proceed to a glenoid augmentation, much like a Latarjet. If it's a small defect in a high-demand contact athlete, in my hands this would be an arthroscopic double-row stabilization. If it's a low-demand individual, an arthroscopic single-row stabilization with mattress sutures. And if it's a moderate defect, probably an open Bankart versus an arthroscopic double-row in that setting. On the soft tissue side, if it's a high-demand athlete with a first-time dislocation or one with recurrent instability, and they're a contact athlete, this would be an open Bankart versus an arthroscopic double row. Non-contact athlete, again, an arthroscopic single row with mattress sutures. And if it's a low demand or low risk individual, rehabilitation. So in conclusion, I think it's important to identify athletes at risk for failure of arthroscopic Bankart. I think the first time in this risky cohort is the best time. And I think it's important to convey to the patients and their family that surgical stabilization reduces the risk of recurrence, but it remains high compared to older cohorts. In my hands, advanced arthroscopic techniques are performed with larger Bankart lesions, smaller capsular injuries, and smaller bone defects. And I would move to an open stabilization for those with greater degrees of preoperative episodes of instability, smaller Bankart lesions, larger capsular injuries, and small bone defects. With those with larger bone defects or large bipolar lesions, a bone augmentation such as the Latarjet would be my best choice. Thank you for your attention.
Thank you, Frank. That's great information. Now let's hear from Dr. Andrew Green. Andy, your thoughts?
Thank you, Tom and Mark, for the opportunity to provide commentary on anterior glenohumeral instability. I want to take a few minutes to emphasize several key and important points on the subject that Frank just presented. It's critically important to understand the pathoanatomy that underlies this condition as it forms the basis for the evaluation and management. Anterior capsular labral injury is present in almost all patients with a traumatic mechanism of injury, and there are varying degrees of glenoid bone loss. Acquired and underlying generalized ligamentous laxity also plays a role in some of the patients. Humeral-sided Hill-Sachs lesions are also relevant in a small number of patients, and I'll touch on that later. Glenoid bone loss decreases both the breadth and the depth of the glenoid and predisposes to recurrent instability. Hill-Sachs lesions are very common, but not usually the primary problem unless they involve greater than 25% of the articular segment or extend beyond the glenoid track on the humeral head. When considering the surgical management of any orthopedic condition, it's always necessary to have a good grasp on the natural history of the non-operative treatment. Hovelius has probably provided the best reported documentation of this. In 1996 in JBJS, he and co-workers reported on a prospective study with 10-year follow-up of recurrence rates and clearly demonstrated that younger age is associated with higher recurrence rates. In 2008, they followed up their original report with a 25-year follow-up of the same cohort and demonstrated that nearly 80% of the patients, regardless of their age, with recurrent instability, eventually underwent surgical management. The non-operative treatment has unclear and variable effects on recurrence, although external rotation bracing appears to have some merit on an anatomic basis, as that position may reduce the labrum and allow better healing after a first-time dislocation. Unfortunately, immobilization is fraught with issues related to the timing of institution, patient convenience, and compliance. And I would say that most of my patients report briefly wearing a sling until they are comfortable and then return to their activities. It's important also to consider the historical background of the surgical treatment of anterior glenohumeral instability. All of these procedures listed here were developed with some theory based upon an understanding of the pathoanatomy. Unfortunately, although some were on target, several were not. Nevertheless, experience with the less than ideal procedures helps us to understand the several aspects and concepts of our current treatment. I think that most of us consider the open Bankart the gold standard, as it treats the primary pathology, the capsular labral injury, and generally has a high success rate. The advent of arthroscopy led to the development and evolution of arthroscopic instability repairs, which are now routinely performed with suture anchors in various constructs. In 1994, Arthiero and co-workers reported an early experience with arthroscopic repair after first-time dislocation in Army cadets and demonstrated a dramatic reduction in recurrence rates. This has led to increased study and emphasis on primary repair for anterior glenohumeral instability. Bankart greater and longer experience has led to the identification of limitations of arthroscopic repairs, primarily related to glenoid bone loss. And Burkhardt and De Beers pointed this out and recommended reconstruction with a Latarjet procedure to restore the glenoid anatomy. Hill-Sachs lesions on the posterior humeral head have recently garnered more attention, but in most cases I would say they can really be ignored. Anterior glenoid reconstruction will prevent engaging of the humeral Hill-Sachs lesion and correct instability in most of these cases. Remplissage is a recent addition to our armamentarium for the management of more complex cases with essentially a tenodesis of the infraspinatus into the Hill-Sachs lesion. The goals of surgery are to restore glenohumeral instability, preserve motion, and restore function with a low recurrence rate and minimal morbidity. The indications for surgery include primary dislocation, recurrent instability, and failed instability repairs. Complications are important to consider, and arthroscopy has lower peri-operative complications than open repairs, of which the most common complications of import are infection, nerve injury, and subscapularis failure. Later complications and problems include failure of the repair with recurrent instability and glenohumeral arthritis after surgical repair. However, untreated traumatic anterior instability rarely leads to shoulder arthroplasty, at least so far in my practice and many others' experience. Dr. Cordasco nicely described the risk factors of recurrence, and I would add to that poor technique. This is also critically important, as Frank has discussed in his review, because a bad repair leads to failure and complications and good technique leads to optimal restoration of anatomy. The following is my approach to the management of anterior glenohumeral instability. I assess for bony defects, and I participate in a shared decision-making process with my patients that includes reviewing published information on their natural history and discuss the various treatment options. I generally offer primary arthroscopic repair to all active patients below age 30 or so, and it's hard to define that cutoff, but primarily because it has a low morbidity, I think it's relatively easy recovery, and a relatively high success rate. And in addition, it is much easier to revise a failed arthroscopic repair. We have to remember that all approaches, including open approaches, have some rate of failure that we may have to deal with in a later procedure. I consider open repairs for recurrent dislocations in high-risk patients, as Frank described, and I tend to do a Bankart, open Bankart, for glenoid bone loss less than 10% and a Latarjet for bone loss greater than 20%. In addition, I do an open repair for most revision cases. The importance of glenoid bone loss to the success of surgical management has become increasingly apparent, and mild glenoid bone loss of less than 10% can generally be ignored. Moderate glenoid bone loss of 10 to 25% can be addressed with a patient-specific repair, addressing patient demands and risks, with a lower demand patient having an arthroscopic repair, and a higher demand patient either an open Bankart or a Latarjet repair. I think severe glenoid bone loss of greater than 25% requires bony reconstruction either with a Latarjet or free bone graft. So to wrap up on my comments, successful surgical management of anterior glenohumeral instability requires a careful, thorough evaluation of the patient, a clear understanding and rational consideration of the pathologic anatomy, and performing a surgical repair, whether it's arthroscopic or open, that addresses the pathoanatomy of the patient. I thank you for your attention and the opportunity to present.
Thank you, Andy. Appreciate your input. What do you think are the major advances in the surgical treatment of anterior glenohumeral instability?
So, Tom, I think the major advances really relate to our improved understanding of the details of the pathologic anatomy, such as glenoid bone defects, ligamentous laxity, and humeral bone defects, and how they contribute to instability in the first place, and how we address them surgically. I think while it's easy to accept successful repairs, and obviously we're happy to have successful repairs, I think this better understanding has really helped us to understand the failures, especially more recently the difficulty with arthroscopic repairs, and I think better clarified the utility and benefit of open repairs in current times with the types of patients that we manage to get successful results.
Thank you. Very helpful. Our next commentator is Dr. Brad Parsons. Brad, let's hear your insight on the surgical techniques.
Well, thank you, Tom, and I appreciate you and Mark offering me the chance to participate in this great webinar. Both Frank and Andy have given us great insight into management of anterior glenohumeral instability for some of these challenging patients. And I think the key points that everybody has already heard warrant a little bit of further discussion, and that's, as you've heard from our prior speakers, a careful preoperative assessment looking at how we quantify some of the soft tissue and bony issues that the patients have when they undergo, when they have had instability episodes. I think the idea of a first-time dislocator potentially needing surgery has gained some traction over the last few years, and certainly I think that warrants some further discussion. As you've heard from the prior speakers, we need to be able to identify bone loss, and particularly the glenoid is the issue that we are most concerned with, and so I'll highlight some of my thoughts on that. I'll go through some of the arthroscopic surgical pearls that I've learned over my career and highlight some of those things that I think can help a surgeon gain that successful repair that Andy said was so important. I'll talk a little bit about when I decided to do an arthroscopic repair or an open repair or a Latarjet, as you've heard some of the prior speakers discuss. And then, as Andy alluded to, the Remplissage to manage some of our heel sac defects, again, has gained some traction over the last few years, and I think warrants a little bit of discussion as well. Certainly the ISIS score, as has been presented by Pascal Ballot, is clearly weighted towards a Latarjet procedure. If you look at the score breakdown, as Frank alluded to, just being a young person in a contact sport with any instability episodes is going to yield that 3-point score, which points the French surgeons, many of them, to doing the Latarjet. And I think it's important to understand all the factors in the isis. Not just the sport they play, but the receiver with their arms are going to be up. Are they a back player or are they athletes or football player? Those all go into my decision making as to what we do for these patients. Not only that, but often these patients get an instability episode maybe at the beginning of the season or at the end of the season, and that has a factor on what we decide to do and how we approach management of those patients. Certainly, as Frank alluded to, the number of episodes of instability is a clear bad prognostic factor to the success of repair. And you also have to look at not just the number of episodes of frank dislocations requiring a reduction, but also the perceptions that the patients have of subluxation or instability episodes, because those can have impact on the degree of soft tissue damage as well. We know from numerous series that the consequences of recurrent stability can be quite profound. You can see on the images on the right, the severe Hill-Sachs deformity and glenoid bone loss can approach even upwards of 40 or 50% in some severe situations where it failed prior stabilization procedures. I think the series presented by Frank from HSS is really a profound and good one. And it shows us the consequences of not only recurrent instability, but the potential that yields to failure of repair. So in their series, as he highlighted, the first-time dislocator has a 0% recurrence rate in their hands. But simply a 5-fold time of dislocation or recurrence of instability, 50% failure rate. And so that's a really concerning statistic to me, and I think warrants a discussion with your patient, and you may opt to go another route in those highly recurrent, unstable patients than just a simply arthroscopic stabilization. And it certainly begs the question, should we be operating on more first-time dislocators, especially young folks at high levels of activity in sport? Certainly these patients that have more frequent episodes of instability, they're going to be ones where we are most suspicious for more episodes yielding bone loss. And so when you're thinking about bone loss and instability, I think you have to think about it with a high index of suspicion, multiple episodes, you need to look for it. As Frank alluded to, the ease of instability, if they're coming out in a mid-arc of motion rather than just extreme abduction or external rotation, that's a concerning sign for glenoid bone loss or engaging Hill-Sachs lesions. And I would tell you it's more common than not. On this X-ray, you might appreciate at the bottom of the glenoid rim, there's loss of the sclerotic line at the equator. And that's a clear sign of glenoid bone loss, and many plain films, if done well, can appreciate these issues. But for me, as the authors have previously presented, if there's any question with a patient with instability, you need advanced imaging. Often patients come to my practice with an MRI already done, and as on the top right, that will show ALPSA-type lesions or soft tissue issues. You can look for the rotator cuff, as Frank alluded to. But for me, a CT scan is often the test I will do, and I've learned this from my European colleagues that a CT arthrogram can actually be quite helpful. It'll show you a little bit of the capsular volume. It might appreciate some degree of a Hagel lesion or other issues, but it really will highlight the bony issues, especially in the glenoid. And so you can see on the bottom left how the CT arthrogram profiles the labrum, but identifies that small bony Bankart, which is going to have an impact potentially on how you decide to manage these patients. The CT also helps differentiate a fracture or a bony segmental injury, shown at the top left, versus an attritional lesion like on the bottom right, where you have bone loss that's effectively been whittled away through the recurrent episodes of the patient. I'm not much of a mathematician, but I find trying to quantify glenoid bone loss very difficult, as Frank and Andy have discussed previously. I tend to try to do simple techniques to help me understand when I have a significant bone issue greater than 20%. I like to use Christian Gerber's technique where he describes the rise of a run where the radius is doubled, and if that's greater than the tangential line X on the bottom right illustration or schematic, then that's a significant bone loss greater than 20%, and I might consider a bony procedure in that patient. When you decide on surgery, if you're going to proceed with an arthroscopic approach, I think there's some pearls that I've learned that can be helpful. So I tend to use a lateral decubitus position, as opposed to Frank, who uses a beach chair position for my arthroscopic stabilization. I find it allows me to visualize the inferior capsule and allow for capsular plication and inferior work at 6 o'clock to be a little easier in my hands. I tend to use a 3-portal system. I mark out the acromion. I have a high posterolateral portal on the right a anterolateral or rotator interval portal in the center, and then a low anterior portal just above the subscapularis. And I put cannulas in all three portals that allows ease of maneuvering of equipment back and forth. The key in the procedure, especially in a recurrently unstable patient, is that anterior capsulolabral complex is going to be medialized and scarred, especially in the ALPS situation. So we have to learn how to mobilize those tissues carefully, because if you try to repair it under tension, it will often fail and result in a failed repair. We've learned from some authors about anchor placement, and I'll go through some of my thoughts about that. In some situations, you need to get inferior access at 6 o'clock, and so a low portal posterolaterally, so-called suicide portal, which is along the posterolateral corner of the acromion, but a few centimeters down the arm, can be quite helpful. It allows you excellent access to the 6 o'clock position and allows for a trajectory for you to be able to put an anchor in the glenoid. And so I'll use that if I have a 270-degree labral tear or a more inferior capsulolabral injury that requires repair. It can also be quite useful for a posterior Hegel or anterior Hegel if those are going to be done arthroscopically. These illustrations and pictures from arthroscopic procedure show how that capsulolabral complex on the top left initially is scarred and deep or medial to the glenoid rim. And you have to meticulously mobilize those tissues to get them to freely float up to the edge of the glenoid rim so they're under no tension during repair. One of the keys, as is shown on the bottom left, is you want to visualize the subscapularis muscle. That tells you that you've released the scars enough that the tissue is now freely mobile, and it's one of the things I look for to make sure I fully mobilize my complex so it gets a tension-free repair. Pascal below has taught us that you need to use at least 3 anchors in a recurrently unstable or Bankart repair for maximal strength of your fixation of your capsulolabral complex. In patients who have had a single episode of instability, a first-time dislocator, I'll use a 3-anchor repair as is shown on the schematic with the anchors placed between B and D along the anterior inferior glenoid rim. I like to put the anchors up on the face so that the healing process occurs along the glenoid neck and side rather than up on the cartilage. It helps restore that normal anatomy that Andy said was so important. In recurrently unstable patients, I'll often add a 4th anchor at the bottom posterolateral corner of the glenoid. And I'll actually start with that anchor first, and that allows me to tension the posterior inferior capsule, and then when I try to translate or reproduce Neer's idea of a classic anterior superior shift of the capsule, it gives me a check rein to tighten that anterior inferior capsulolabral complex and restore normal stability of the ligamentous aspects of the shoulder. So I like that additional 4th anchor in patients who have had more episodes of instability. How do I decide when I'm going to go arthroscopic? As Andy has alluded to, and I think Frank has as well, most of my techniques these days in most patients are going to be an arthroscopic repair. Even small bony fractures can be treated with a double row bony Bankart type repair. It's been popularized by Peter Millett. And so in my hands, most patients with recurrent instability or first-time dislocators are going to be treated arthroscopically. Latarjet is reserved for patients who have had failed prior instability surgery and have bone loss along the glenoid rim or a significant Hill-Sachs where I'm concerned about the engaging lesion, and the Latarjet can solve that problem in many ways. But often, some of these patients have no bone loss, and so I would not abandon the open Bankart repair or soft tissue repair, as Andy and Frank have both alluded to, because that can be a very powerful repair in a patient who's failed prior instability surgery. The controversy that's been highlighted tonight is that you often have patients that have a little bit of bone loss, a high level of activity, a high level of sport, and they tend to be younger people. And as Andy alluded to, I think you need to get these patients involved in the discussion, engage them in options, and have them be educated so they can make the best decision with you. And finally, I'll finish with the ideas of remplissage. This is certainly an idea that has been popularized over the last few years with the concept of the engaging Hill-Sachs and dealing with failure of soft tissue arthroscopic stabilization. As Frank has pointed out, if you have a Hill-Sachs and external rotation on a Gracie view, that's a large, deep, bony lesion, and you have to be aware of that. Often we'll see it on internally rotated x-rays, as is shown here. And I think if you're going to do a remplissage, fully in the procedure, because technically it gets much more difficult later on. You want to try to imbricate that infraspinatus muscle into the edge of the glenoid rim so it meets and fills that Hill-Sachs defect. And I'll tend to use it in situations where I'm concerned about failure of my soft tissue repair, but hopefully we can discuss that further amongst the panel. So in summary, I think we've highlighted tonight the complexities of instability in patients who are young and demanding. I think you have to have a high index of suspicion of glenoid and humeral bone lesions, and there's an armamentarium of options available for us to try to treat these patients. And I would encourage you not to abandon the open Bankart repair because it can be quite powerful. But as we all know, most of these patients are treated with arthroscopic techniques or Latarjet if they have significant glenoid bone loss. So I thank you for your attention.
Thanks for sharing your perspective, Brad. Before moving on to the questions from the audience, I have a couple of questions of my own. First, Frank, why not perform a Latarjet in most patients as they appear to advocate in France?
That's a good question, Tom. And I think in my hands, I've found effective ways of managing the shoulder without a Latarjet. And, you know, I'm old enough to remember that many of our instability operations years ago, both with the shoulder and the knee, were extra-articular augmentations and sort of non-anatomic reconstructions. And in my hands, I'd prefer to attempt to restore the anatomy, and I reserve bone augmentation procedures like the Latarjet really for those patients who have significant degrees of bone loss or have capsular insufficiency and many failures.
Tom, I'd like to comment on that as well, if I can. This is Brad. You know, one of the concerns I've had with Latarjet is, you know, when I was a young person in practice, it was really gaining excitement, and I started to do it often in patients who had some bone loss. And what people may not appreciate is it's not a completely benign procedure. There's risks that are not inherent to other stabilization procedures, such as hardware failure, non-union of the coracoid, and as J.P. Warner has shown us, an increased risk for nerve injury. And so although it's a very powerful tool, as Frank just said, you know, there are many cases where you don't have to resort to that. And sometimes in older folks over the age of 35 or 40, they don't do very well with the Latarjet. At least I found that in my hands. So I think we have to be a little bit thoughtful about how we apply that type of procedure to patients with instability.
Thanks, Brad. Now I have a question for you. How do you decide when to operate on the first-time anterior shoulder dislocator?
Well, I think it's challenging. I mean, often you have a 17 or an 18-year-old athlete in your office, and the parents are concerned. It's the beginning of the season. Perhaps they're a football player or they're a baseball or softball player, and it's their throwing arm, and they've had a traumatic episode of instability. It might be their junior year. They're thinking about college. All those factors that make everybody anxious. And I think what we've learned, especially in the last few years, is that recurrent episodes is not benign. And so if the patient's a high-level person, a high-level athlete, they have goals to continue that level of activity, they're young, and it's their dominant arm, that is a patient I often encourage to consider surgery. And older folks in their 20s or 30s for instability, we might consider a trial of non-operative treatment. But that young athlete in high school or college age who's still wanting to maintain their sport activity, I've gone to become a little bit more aggressive with those folks.
Thank you. That's very clear.
And Tom, if I can add a comment to that as well, I think Brad's response was great. I think what's happened over the years is, it's kind of a trickle-down effect in that what works well in an NFL athlete to get them through a season using some type of an adduction brace is very effective in that setting, and they can be treated at the end of the season. The difference in the high school athlete is, number one, it's a different population. They're at higher risk than a 25-year-old. And secondly, they're young adolescent males, and they don't have an entire support system surrounding them in the form of focused athletic trainers to manage them through the course of the season. Dan Buss published a very nice paper talking about use of harnesses during in-season situations in high school and college, and it was fairly effective, but nearly 50% of them wound up with surgery at the end of the season. And I think the second point I would make is that the first dislocation is often the most traumatic and the most painful to the athlete. Subsequent dislocations tend to be less symptomatic, and as Brad and Andy mentioned earlier, subluxations are more difficult to quantify. So my point is, if you're advising a high school athlete after their first-time dislocation to treat it non-operatively, and then they have multiple, in their minds, less significant events during the season, before you know it, they've had 4, 5, or 6 instability episodes, and that places them in that very high-risk group. So if one is going to manage them non-operatively, you really have to manage them very carefully and with careful observation, communicate with parents, coaches, and athletic trainers in that high school situation.
Tom, could I add just a comment to that? It's Andy. I think one of the other things that we're probably seeing is a change in the demographics of the patients that we're treating, whether it's different sports activities, snowboarding, skiing, dirt bikes, things that are high risk, and probably people being more involved in those sports at younger ages. A lot of organized football and other sports that put people at risk for instability. And I think that, and I'm not sure if everyone else has seen this as well, but I think we're talking about a group that maybe 20, 25 years ago wasn't as prevalent. And because of that, I think we're adapting our approaches to this, and that's where the primary repair comes into play. I think you have to be very clear with the parents and the kids, what the expectations are. And I think one of my problems with the adolescent males is after you fix them, they don't always rehab as well as the little bit older player who's in an organized setting, and they're at higher risk, I think, for re-injury, which I think can lead to recurrence as well, even with a successful repair.
Thanks, Andy. The time has come to move to the question and answers, and we have a bunch of good ones. I'd like to start with one about rehabilitation, and it's directed to Frank Cordasco. Frank, what restrictions do you want when you repair a bone defect, similar to what you presented in your video?
Well, there are two issues there. The video was really an arthroscopic double row repair. So if I've repaired an osseous Bankart lesion using that technique, I think the key is I'm obviously happy with the fixation when I leave the operating room, or I would move to something else. But I would manage that patient much like I would manage a standard arthroscopic stabilization. And I tend to be fairly conservative. I do immobilize them in a sling for the first 4 weeks. If I'm concerned about the integrity of the bone, I might immobilize them for slightly longer. And then the second phase is really about restoring range of motion. That may last for an additional month. And the third phase would be to begin a strengthening program. So it's a fairly standard approach. I would manage it a little bit differently with a procedure like a Latarjet because it is an open stabilization. In essence, I would tend to favor moving it more quickly than I would standard soft tissue stabilization performed arthroscopically.
Thanks.
Frank, when do you let your Latarjets go back to contact sports? This is Brad, sorry.
Yeah, that's a good question, Brad. And, honestly, the end game for all of these operations is pretty similar in my hands. I usually tell the athlete on the front end that it's going to be at least 6 months. I make it clear that it's not just chronology, that they'll have to hit certain benchmarks along the way in terms of a return to play program so that they're also working on their core and their lower extremities. But in general, I think that's a reasonable expectation. That is that they'd be allowed to get back, not to full capacity, but in a contact situation at 6 months, it might be longer, 8 to 9 months before they're back to full capacity on the field.
Okay, question for Andy. Let's talk a little bit about multidirectional instability. How do you treat patients with multidirectional instability versus unidirectional instability in regard to surgical treatment when conservative treatment has failed and the instability continues?
So the classic patient with multidirectional instability is someone who has not had a traumatic injury and has bilateral shoulder laxity. The affected side generally presents with pain as opposed to subluxation or dislocation. And most of those patients we try to treat non-operatively with periscapular strengthening, rotator cuff strengthening. And for the smaller percentage that fail, I typically do an arthroscopic capsular plication or capsular shift with the rotator cuff interval plication. I rarely ever do an open capsular shift as described by Neer. I probably haven't done one in 15 years or so. And I find the arthroscopic plication is very effective at tightening those shoulders and balancing them, and then going slow with the rehabilitation because these are patients that tend to stretch out whether you do an open or an arthroscopic repair. And I found that very effective. there is a small group of patients who have a traumatic dislocation who have underlying laxity or multidirectional instability, and I think the way to pick those patients up is to examine their other shoulder and see whether their other shoulder is loose, because that's what their normal glenohumeral translation is going to be, and then tailoring the repair of the capsular labral injury on the traumatic side to include some degree of capsular plication or rotator cuff interval plication to augment the labral repair, because those patients tend to be looser and more likely to have recurrence in my hands.
Frank, would you address anterior-inferior instability without labral pathology by arthroscopic capsular plication or open capsular shift?
I would agree with what Andy just said along the lines of MDI, and in general, I always start arthroscopically. I get a good look at the quality of the tissue. If I'm concerned about the tissue from a qualitative standpoint and I feel I need to really reconstruct it from outside in, I'll move to an open approach. But for the most part, I'll manage these patients arthroscopically, and I would echo what Brad mentioned in his technique portion of the discussion. I do think it's important to, in this setting in particular, but also with standard anterior instability, to look circumferentially. You know, Russ Warren talked about this many years ago in terms of the full circle concept. That is, when athletes have an instability event anteriorly, they will often damage the tissues posteriorly. And so I often use the analogy with patients that the glenohumeral ligaments are sort of like a hammock. And if you're repairing one end of the hammock on the glenoid, I'll often move to the back side as well and place some sutures and anchors in that side as well to really, as Andy just mentioned, to balance the glenohumeral ligaments both anteriorly and inferiorly. So yes, I will proceed arthroscopically unless I'm concerned based upon factors that I note intraoperatively.
Okay. One of the members of our audience has asked a question that he'd like each one of the speakers to comment on, and that's, can you comment on your treatment algorithm for acute shoulder dislocation after closed reduction? Do you get immediate CT or MRI, and do you get follow-up MRI? So, Brad, why don't you handle that first?
Well, it depends on the patient age and what happened to them. So in a young person who's 18 or 19, and I'll get plain x-rays to make sure they don't have a fracture if they haven't already done that. You know, sometimes the patient goes to the emergency room and they see a dislocated shoulder and the ER doctor won't even get an x-ray. And so I think any dislocation, unless reduced on the sideline, if it's in a hospital setting, at least in my opinion, should get at least a plain x-ray to make sure there's not a hairline fracture or something occult that wasn't appreciated. So assuming the plain x-rays are normal, in a young person where the risk of rotator cuff pathology is low, I'll assess the rotator cuff with a cursory but simple examination to the side. If the rotator cuff looks intact, I don't routinely get an MRI in those patients unless we're considering surgical management after a first-time episode. An older patient for instability, as Frank alluded to, 35, 40, 45, if there's any question on getting an MRI to rule out a rotator cuff tear or pathology like that. And then, as I said in my talk, if someone's had recurrent episodes, I'm worried about bone loss, as my index secondary type intervention or imaging study, I'll get a CT arthrogram. I don't always resort to an MRI in some of those situations because I think it helps me identify the primary pathology a little better.
Andy, your thoughts?
So the same idea. The patient age is very important because that dictates the type of pathology. In the older patient, above age 40 or so, and we want to do a good exam to make sure they don't have weakness in internal or external, and consider getting an MRI to evaluate for rotator cuff tear. In those younger patients, I base my decision on whether or not the patient is going to have primary surgery for that first-time dislocation. If they're going to have surgery, then I'm going to get an MRI to evaluate, to make sure that they have a labral side or glenoid-sided injury and not a Hagel lesion, which is rare but very difficult to repair arthroscopically. And I don't think you need contrast after an acute dislocation because there's blood within the joint. And tend not to get CT scan after the primary unless there's a significant bony lesion on either the glenoid side or the humeral head, which I can pick up on the plain x-rays, because if I'm going to operate, I want to know how big is the lesion. Is it an acute glenoid fragment that I can fix with the bone fragment, or is it small? In patients with recurrent instability, I typically get a CT arthrogram if I'm considering reconstruction for instability.
And Frank, how would you answer this?
I would agree with what Brad and Andy have just said, and I don't have anything to add.
Okay. Let's see. We talked about, do you think we talked about the timeline for returning to sport adequately? Anybody want to comment on that?
I think it really depends on their sport. You know, if it's a wrestler, I'm much less inclined to let them go back before 9 months or so, because I know they're going to be in a position where they are at risk. If it's a football player, it depends more on what position they play, and really the risk factors in terms of that. And I think Frank really touched on having milestones. They need to have regained their strength and demonstrated that. They need to have motion. If someone has limited mobility, I think that's a risk factor for re-injury.
Yeah, I mean, the other thing, Tom, that I would add to what Andy just said and what Frank said before is we're often getting pressure from a lot of people outside of the patient. So parents, if they're young, coaches or trainers, people who want to get the athlete back. And certainly for people taking care of high-level collegiate or professional athletes, that's even more of a pressure. And we all know, as we've discussed tonight, the failed arthroscopic repair or the failed open repair can be a very difficult thing to successfully manage. And so your best chance of success is a well-done repair, as I think we've all discussed, and then appropriate rehab that hits the milestones that Frank very nicely pointed to. And the worst thing you can do is rush someone back before their soft tissues have sufficiently healed, their strength is right, their mechanics are right, and you're putting them on a primrose path for a real problem down the road. And so I think we have to be cautious about that for these patients.
Brad, do you agree, or do you have some other thoughts?
So that was Brad. Sorry.
Yeah, I would say, Tom, this is Frank. I would say that I agree with both Andy and Brad, and I would just highlight one additional thing. I think age is a factor, and as both commentators mentioned, it's easy at the professional level. It's almost Darwinian. They've certainly achieved that level of capacity before the injury, and it's easier for them to get back to that level. And in particular, it's their day job. They have 4 to 6 hours a day to work out in a state-of-the-art facility with 4 trainers. Most high school students, between SAT and ACT testing, playing the violin, and then getting their sport in, really don't have the ability to do that. And yet the pressure at the high school level is often greater than it is at the collegiate or professional level. So I would caution the participants to go slow in that population and really rein those young athletes in, because they're probably the least prepared to get back to sport earlier. And of course everyone looks towards the sports pages and sees what our professional athletes are doing and how quickly they get back. And that's probably not the best standard or benchmark.
Great insight. Well, I think we're going to wrap up the question and answer. And I just want to communicate with the audience. The content forming the basis of this webinar was published in JBJS Reviews, which JBJS launched in November 2013, a journal to bring you the best-in-class review articles. For the past 18 months, U.S.-based orthopedic surgeons have received complimentary access to JBJS Reviews. That 18-month free trial period has now come to an end, but you will have the opportunity to subscribe to JBJS Reviews at the close of this event following a brief survey. Before we close tonight with Dr. Swinkowski, I want to thank our speakers for their presentations, and I'd like to thank you all for joining us. As you exit this webinar, please take a moment to fill out the short survey, which will help us evaluate this presentation as well as plan for future webinars. I hope you found this session valuable.
I want to thank Dr. Einhorn and all the speakers for putting together today's webinar. We hope that you've enjoyed this presentation. This webinar will be archived for 6 months in the event you or your colleagues would like to listen again. Enjoy the rest of your evening, and we hope to continue to bring you information in formats that are convenient for you. Thank you, and good night.